So history is very important to rule out any complications associated with chemotherapy or radiotherapy.
So I think that you decide based upon the clinical history as well as the radiological findings, and if required, then you would like to do a biopsy, or in some cases, otherwise.
Definitely, biopsy is most of the time. If you see the go for the biopsy in to rule out complications, they are very non-specific. So
Non-specific.
biopsy and the patient is very friable. So we generally avoid to go for the biopsy. Generally, we do for the CT scanning and the clinical history. That is the most important things to rule out any complications associated with chemotherapy or radiotherapy.
Thank you so much. Thank you so much, both of you, for sparing your time with us, and also your colleagues and our colleagues in pulmonology. And thank you from the oncologists also for fighting coronavirus on the forefront. And we are very happy.
Thank you,
Thank you,
Vas.
sir. Thank you. I told you that we have to to remind you that we have also have to treat corona. Besides corona, we have to treat so many things. So
Yeah.
thanks. After 6 months, I am speaking about something else.
So, yeah. Thank you so much. Thank you,
Okay.
both of you.
Right, Vas.
And please stay here because we'll have some more questions which will be directed towards you. So
Okay.
for the next session, I'd like to invite Dr. Munish Garola, and he is Director of Radiation Oncology at Rajiv Gandhi Cancer Institute. And sir has vast experience, and we would like to listen from him about SBRT. So SBRT is one new thing which is happening in lung cancer, and I think more and more data is coming up where we are able to choose patients who might be able to not undergo surgery and be directly taken up for radiosurgery. So that will be very interesting to listen from him. Welcome, sir, and over to you, sir.
Thank you, Dr. Sajjan, for inviting me and for giving me this chance. I think after the conventional lot of pulmonary talk, now we are coming, and that to such a specific talk like SBRT. You have given me a task of speaking the SBRT or SABR. It is that means stereotactic body radiotherapy or stereotactic ablative radiotherapy in NSCLC. So before coming to the topic proper, let me give you a brief background and very basic thing that what is actually the stereotactic radiotherapy. Stereotactic radiotherapy or SBRT it's a non or minimal invasive form of radiotherapy. It actually is precisely targeted radiotherapy to tumor and is delivered using a well-defined three-dimensional coordinate system located accurately in the space any desired region of the target. So the hallmarks of stereotactic radiotherapy are it's a high precision, sub-millimeter accuracy, a rapid dose fall off, and of course the high dose conformity. These are a little bit technical things. So now the coming to the topic proper, and so I shall be discussing my presentation in case group in these two headings. One is medically inoperable early lung cancer, and on the request of Dr. Sajjan, he has insisted me that I should talk something about role of SBRT or SABR in medically operable early lung cancer as well. So, but first I would be taking the medically inoperable early lung cancer role of SBRT. SBRT or SABR for extracranial targets was first conceived and successfully implemented by Blomnang et al. At the Karolinska Institute of Hospital at Sweden. If you see, as you can see here, the table, many retrospective and prospective studies were carried out since 1990s to early pre-2010. But all suggested, and all of them, they are suggested good local control with as high as 97% 3-year local control by Timmerman group. You can see here up to 97%. But most of the radiation oncologists and non-radiation oncologists wanted level 1 evidence in terms of randomized trial in favor of SABR or SBRT. However, most of the guidelines and in general, the scientific world accepted that SABR is an alternative to medically inoperable lung cancer. You can see here two large retrospective non-randomized study, one by MSKCC and other by the National Cancer Database, along with one systematic review done by the Australian group, have reported a survival benefit associated with SABR compared with standard radiotherapy, as well as decreased toxicity. But still, the question remained unanswered in terms of lack of randomized trial and local term safety profile. That is until two trials, one is SPACE and one is Chisel came. So I will be discussing a little bit in detail of these two trials. The SPACE trial was a phase 2 trial which was initiated by Swedish community. It was designed to assess the primary endpoint was PFS and secondary endpoint was OS, and the side effects profile as well. Keeping in mind the phase 2 design of this trial, it was seen that there was no difference in PFS or OS. However, health-related quality of life and late toxicity were better with SAPR. Toxicities, as Dr. Nitin was mentioning, pneumonitis, chest pain, esophagitis, dyspnea, were statistically worse with the conventional arm of radiotherapy. This is again another trial. This is first phase 3 randomized control trial, which studied the biopsy-proven early stage medically inoperable lung tumors and further divided into SABR versus conventional radiotherapy. As you can see here in this Kaplan-Meier, both primary and secondary endpoint like freedom from local treatment failure and overall survival was statistically significantly better in favor of SABR or SBRT. So the conclusion of these two trials and everything, especially, the only difference was, here in these two trials, in SPACE there was no benefit was seen, while in Chisel there was an advantage of of PFS and OS was seen. And the question is why? Because if you compare these two trials, all patients in Chisel had compulsory PET staging, unlike SPACE where PET staging was not compulsory. Only 60% patient they underwent the PET staging in this space. Another difference was there was better ECOG performance status patient was seen in Chisel rather versus SPACE. Motion management compulsory in Chisel, but it was optional in SPACE. This is a little bit technical part of giving a radiation. And finally, if you see the dose, the lesser dose, radiation dose was given in SPACE versus Chisel. In SPACE, the dose was only 45 gray, while in Chisel trial, the dose was 54 gray. And that is why these may be the reasons that in Chisel, they had shown both PFS and OS advantage of giving SABR. Now another, so the conclusion of this medically inoperable SBRT, role of SBRT in medically operable lung cancer or NSCLC is SABR has replaced conventionally radiotherapy for early stage lung tumors, especially in the treatment of elderly patient. And lot of, there are various, you can very well see that various dose fractionation schedules are recommended, starting from 3 fractions of 18 gray versus up to 8 fractions of 7.5 gray, depending upon the location of the tumor. And in few cases and few centers, they have used even, single fraction of real ablative dose of radiotherapy up to 30 to 34 gray. Now, the second part of my talk is role of SBRT or SABR in medically operable early lung cancer or early NSCLC. This is one of recent publication which is enumerating the pros and cons of opting surgery versus SABR in operable lung tumors. What was interesting to note, apart from the data from this publication, is one of the biggest factor that impacts the generation of evidences is the specialty of first author, which plays one of the biggest confounder in the literature. Uh, as you can see in the table, patient undergoing SABR have excellent outcome. Also, uh, also the only two phase 3 trials, you can see that only two phase 3 trials initiated were incomplete due to poor accrual. However, the pool analysis showed of these two trials showed a 3-year overall survival of 95%, which was statistically significant to surgery arm by 16%, suggesting that SABR deserve more credit than given. Although this pooled analysis has some inherent statistical problem, like the number of patients were lesser, like only 58 patients were in this trial, and poor surgical results were also seen. But again, it is needed to be pointed out here that this is the identical sample size as the original randomized trial, surgery versus radiation at Hammersmith Hospital, that was published way back in 1963 and established the primacy of surgery ever since. Uh, uh, Although there are lack of evidences of SABR for medically operable lung tumors, there are certain subset of the patients, or I would say more precisely, certain circumstances where SABR becomes more preferred option both for the clinician and for the patients. Like you can see here, where in pre-operative biopsy is difficult, one. Another is where the functional morbidity of the surgery is pretty high and unacceptable to the patient. And third, which is again nowadays very, very important, where the patient refusing for the surgery. So these are the few points which, where the SBRT is preferred even in operable lung cancer. Now, if you see the patient who are risk of pre-operative biopsy related complication can easily be taken up for SABR. These have been proven by many prospective. You can see many prospective series when the risk of malignancy for lesion of radiology, especially the PET-CT, is more than 85%. And they can be easily taken up for SABR directly rather than, exposing them to complication related to surgical biopsies, which can be as high as 17 to 21% as per, Nelson trial. We all know that very famous Nelson trial. They have shown the toxicities as high as 17 to 20%, 21% almost. And these numbers are clearly high as compared to the side effects of profile of SABR. These have been, again, these have been included in many guidelines. You can see all the guidelines, almost all famous guidelines, they are including and clearly mentioned the advantage of this thing. One of the key element, again, in decision making of deciding whether to go for SABR or lobectomy is patient preference, which is unfortunately the most neglected element in our clinical practice. We need to empower our patient with efficacy, outcome, and toxicity profile and both the treatment options, and let the patient decide where he wants to go or she wants to go. As clearly seen in this study, Shevardin et al., the 56% of the patient had no clue about SABR before meeting a radiation oncologist, and 90% would have chosen SABR over surgery retrospectively. This was a publication by Shevardin, and he has shown very clearly this thing. Even Astro recommends the SABR discussion as appropriate with the patients. This is a very important slide and given to me by Dr. Suresh Senan, which is a very famous, I would say one of the topmost thoracic radiation oncologists from VU University Hospital, Amsterdam. And he has mentioned very clearly that despite the reluctance towards the SABR by thoracic surgeons, a lot of patient-centric institute and health agencies are moving towards SABR. As you can see from this data by it's from Norway, Netherlands, and England, a drastic increase in SABR and decrease in surgery, especially for elderly in recent years. You can very well see here, all these countries, all these countries like Norway, Netherlands, and of course the England. So finally, I would like to conclude the role of SBRT in medically operable lung cancer is there are no, as such, no randomized controlled trial comparing the surgery versus SBRT or SABR. There are two major ongoing randomized controlled trials which are ongoing and results are still awaited, like SABR tooth and stablemates. If you see the meta-analysis of propensity score studies in early stage non-small cell lung cancer, the cancer-specific mortality, regardless to extent of the surgery, it was with more or less same with SABR. However, all-cause mortality was higher with SABR versus surgery. In studies, survival endpoints were associated with propensity score matching, caliper matching distance, and of course another thing is first author speciality. Finally, despite reluctance, both survival and toxicity data arising for SABR in operable lung cancer. With this, I would like to conclude my talk. Once again, thank you very much, Dr. Sajjan, for giving me this opportunity. Thank you very much.
Thank you, sir, and sir, thank you for covering this very comprehensive topic in a very short span of more than, I would say, 12-13 minutes. You have already covered, and I feel that the way forward for SBRT is there in the next decade. Definitely, we'll have more evidence, and we'll be able to choose our patients more wisely for SBRT, and we exactly know which patients will benefit with SBRT and which should undergo surgery.
Yeah, so I still feel that for operable, still the evidences are more in favor of surgery, but the SABR or SBRT is very much viable option, and a lot of patients, they are suitable for this.
Yes, sir. And that option has to be discussed in the multidisciplinary meetings which we have.
Yes.
For patients. As you told that almost 50% patients won't even have this option known to them. So that's one thing.
Very correct. Very correct.
Is a takeaway from this talk, sir. Thank you, sir.
Thank you.
I'm sorry, we are running 15 minutes behind the schedule, and so I'll just rush up. So the next speaker is Dr. Sushant Mittal. He's head of unit medical oncology at Action Cancer Institute, and he will be speaking on ideal strategy to manage the first-line EGFR positive non-small cell lung cancer patients, the current scenario. Welcome, sir.
So please unmute yourself.
Yeah, thank you, Dr. Sajjan and the organizers for giving me this opportunity. Can I have my slides, or should I can share my screen?
Yes, sir, you can share your screen, sir.
Okay. So this topic is very pertinent to the current scenario when we have so much drugs and testing available as to how to treat the lung cancer patients, and amongst that EGFR has so many drugs in them. So the ideal strategy for managing the EGFR NSCLC patients I will be discussing today. And what are
you have to go full screen.
Am I not full screen now?
Yeah, you have to do the enable editing option. Just click on the enable editing. Can you see?
Yes.
Now you have to go full screen.
Okay, fine. Is it full screen now?
Yeah, sir.
Yeah. So whenever the patient comes to our OPD, the three most important thing what we, on the basis of what we decide is the progression-free survival, overall survival, brain metastasis, symptomatic, asymptomatic, and what is the tolerability, what is the safety and toxicity profile of the drug. So first option is first generation, second generation EGFR TKI monotherapy followed by sequentially by osimertinib. Second is TKI plus chemotherapy or anti-angiogenic inhibitors, its combination. And third is directly starting EGFR TKI, that is osimertinib third generation as the first line therapy. So first, a second generation EGFR TKI monotherapy has shown a consistently PFS benefit of 9 to 15 months, whether it's geftinib, erlotinib, afatinib, and now dacometinib, but none of them has shown any of the overall survival benefit. So osimertinib, with the help of FLORA trial, is one of the drugs which has given us an overall survival benefit. And the study design was to include patients with the exon 19 or L858R mutations, and with stable CNS metastasis patients were also allowed. Another important point to note is that crossover was allowed in this study, and the primary endpoint was PFS, along with secondary endpoint was overall survival. And this, we all know that osimertinib had a significant PFS benefit, 18.9 months versus 10.2, which was significant, and the forest plot suggested that it was significant in along the all subgroup analysis, regardless of the CNS metastases were present at the trial entry or later on, or the age or sex of the patient. CNS metastasis, treated, untreated, both the categories has shown that the benefit is there. As we can see, that orange curve is much more wider and separated from the standard of choice therapy. The separation of curves, this is a cross-trial comparison. It's not an ideal comparison, but what it shows that afatinib versus geftinib, the survival benefit was the curve started separating after 12 months, that is 1 year. In Archer trial, dacometinib started separating from the geftinib at 6 months, whereas in FLORA, the osimertinib started from the first instance itself. It also provided an improvement in PFS to the tune of 18.9 months, as can be seen with these histograms. The Archer trial, that is the dacometinib trial, it did not include the CNS metastasis patient, and also the overall survival was dependent on the overall response rate in the statistical hierarchy calculations. So none of these drugs showed any of the OS benefit, whether geftinib, erlotinib, afa, or dacometinib. In Archer, the curves, as we can see, have crossed each other twice, and according to the FDA, no statistical significant improvement in OS was demonstrated. There was no difference in overall response rate. That's why dacometinib will never be able to show a significant OS benefit in the Archer study. And the OS curve crossed twice in the patient. The group of patients who progressed early appear to have survived longer on geftinib versus on dacometinib. As we can see in the end, the red curve is showing a longer survival, and the dacometinib curve has gone down. And it is not possible to determine which patient will or will not have a survival benefit on dacometinib versus geftinib. So these are the two major caveats in this study. Also, the PFS and OS analysis, there was a flip. The unexplained flip was between the PFS and OS. The Asian patient did better on the PFS, but worse on the OS. And exon 19 deletion patient who did better on PFS, but worse on OS. So in FLORA, despite the crossover, 31% of the patient had a crossover. The overall survival benefit maintained, as we can see, even at the end of 3 years. Archer did not show overall survival, as I told you before. And in CNS also, the osimertinib showed a significant PFS benefit. Safety summary, as many of us have used the drug, we know that it is easily tolerable. The rashes and acne, diarrhea, nail effects, all are well tolerable, and even if there is present, are well managed by our team of oncologists. This study, this graph is important, which shows that in Archer trial in dacometinib, 63% of the patient had more than grade 3 side effects. In erlotinib with bevacizumab, 88% had side effects of more than grade 3. In erlotinib with ramucirumab, 72%. and geftinib with chemotherapy, 75% of the patient had side effects of more than grade 3. However, in FLORA and osimertinib, only 34% of the patient had more than grade 3 side effects. More than 2/3 of the patient had to discontinue the dacometinib because of the side effects, and patient had to be taken on the reduced doses of dacometinib. So the synopsis of why it is important that patient receive osimertinib in the first line is that in a retrospective study, that is GEOTAG, it has shown that patients who are started on afatinib and then taken on osimertinib had a better overall survival. But this trial also had caveats. First and foremost was GEOTAG is a retrospective observation study, and it excluded patients who were T7090M negative or not tested. Also, it had a higher incidence of DEL19 patients. It was not possible to draw a conclusion about the relative benefit of the sequential afatinib with osimertinib versus first-line osimertinib without a direct head-to-head comparison. So GEOTAG has its own caveat, because of which we cannot be sure whether afatinib followed by osimertinib is a better versus osimertinib frontline. Also, this is a well-known fact that 1/3 of the EGFR patients are treated who are started on first line or second line TKI are unable to receive second line osimertinib, either because the performance status decreases or the patients are not anymore eligible to receive the drug, they have died or are have reduced performance status. FLORA is also a kind of a sequencing study because osimertinib was compared to the comparator arm in which first generation TKI was given, and then osimertinib was allowed, as it was crossover was allowed in this study. So the first line osimertinib had a better result compared to the sequencing strategy. Hence, it also solves the question of sequencing strategy, in which the GEOTAG was there. It was a retrospective study, but FLORA is a prospective trial. So because of this, osimertinib in NCCN guidelines is preferred as a category 1 drug, whereas erlotinib, gefitinib, dacometinib are other recommended drugs. So first line osimertinib gives a better efficacy, gives a better benefit in brain metastasis, better tolerated, and the guidelines also says that it is a better tolerated drug. So it ensures a better opportunity to receive treatment option with survival benefit to all patients, as proven by the subgroup analysis also. Thank you.
Thank you so much, Dr. Sushant, for such a crisp presentation and making this a point that osimertinib might be the best choice if finances are not an issue. And I think we'll take up more questions on this in the panel discussion. And next, I'd like to invite Dr. A.P. Dubey, who is consultant medical oncologist at Shanti Mukundan Hospital. And Dr. A.P. Dubey will speak on IM Power 133. Itezolizumab plus chemotherapy in first-line extensive small cell lung cancer. I think it's a very valid area where a lot of things are happening. And over to Dr. A.P. Dubey for this presentation.
Good evening, everyone. Thanks, Dr. Sajjan, for giving me this opportunity. So I'll be speaking on the atezolizumab combination with chemotherapy in first-line extensive stage small cell lung cancer. So I'll be talking next 10 minutes over a topic which is less of talked about under the following subheadings. Small cell lung cancer, it is a highly aggressive malignancy with very high mitotic rates, albeit a very good and better chemo responsiveness, but very limited second line treatment options, resulting in a dismal prognosis. Worldwide, more than 2/3 of the patients present with extensive stage disease, and in Indian setting, the scenario is much more worse, that around 3/4 of the patient will present with the extensive stage disease. Since the disease present with the central mass or the proximal mass, so the disease will present with dysphagia, chest pain, and superior vena cava syndrome. And small cell lung cancer is also the subset of the lung cancer which is associated with large number of paraneoplastic syndrome. It is the disease of smokers, very rarely found in non-smokers. In contrast to non-small cell lung cancers, there is less of concrete evidence of any effective targeted therapies in small cell lung cancer. So small cell lung cancer accounts for around 15% of all lung cancers, and rest 85% is accounted by non-small cell lung cancer. This is very highly aggressive with early dissemination and spread metastasis with very poor 5-year survival rate of less than 2%. As far as staging is concerned, the disease is staged into either limited stage when the whole disease can be encompassed in a single radiation field, or an extensive disease when it could not be encompassed in a single radiation field. If we go with this staging, worldwide around more than 65% of the patient present with the extensive stage, and around 1/3 will present with the limited stage. But the Indian scenario, as I have said, that is quite more worst. Around 3/4 of the patient, means 75% of the patient, will present with the extensive stage disease, and around 1/4 with the limited stage. The treatment is determined by the disease classification. If it is limited stage, the very limited number of patients will undergo surgery. Otherwise, majority of the patient will receive chemotherapy plus radiotherapy. In extensive stage, platinum-based chemotherapy, generally with the combination of etoposide, remains the standard since last 2 decades. This is the evolution of chemo or chemoradiotherapy in the treatment of small cell lung cancer. As you can see, there is no new drug addition in the armamentarium of small cell lung cancer treatment in the first line, and also with the very few or limited second line options. That's why resulting in very poor prognosis in these patients. So treatment scenario in India, as I have told, that the scenario is quite worst in India. More number of patients as compared to the Western population present with the extensive stage of the disease. And platinum-based combination remains the standard for the first-line treatment. Most of the patients will receive platinum etoposide as the first line, and rest around 20% receive irinotecan-based platinum chemotherapy. Very less has changed over last 20 to 30 years. If we say about the limited stage, the 5-year overall survival has improved just around 2.7%, and the rapid aggressiveness of the disease is very well characterized by seeing this overall survival improvement in last 20 to 30 years in extended stage disease. You can see that 2-year survival rate is around 5.9, with 5-year survival rate is a dismal 2.4%. So to summarize, a disease with a very good chemoresponsiveness, still median progression-free survival of less than 6 months, median overall survival of less than 12 months, and a dismal 5-year overall survival of less than 2 months. So, and in last 20 years, there's hardly any change in the systemic therapy in first-line extended stage small cell lung cancer. This is the latest development in small cell lung cancer. I'll talk about the last 2 years, where there's addition of immunotherapy to the induction chemotherapy, either atezolizumab or durvalumab. The difference is that the durvalumab combination was not stratified for significance in progression-free survival, whereas atezolizumab in combination with chemotherapy has shown improvement in both progression-free survival as well as overall survival. So what is the intention of combining a chemotherapy to immunotherapy? As we know, the chemotherapy results in death of cells, which result in release of antigens, and these antigens will be presented by the antigen presenting cells to the nearest T cells in the lymph nodes, resulting in priming and activation of T cells, which further leads to the trafficking of T cells to the tumor, and these T cells will recognize the cancer cells and resulting T cell killing of cancer cells. This would have gone very well until unless there is a PD-1 PD-L1 interaction which results in down regulation of T cells. So this PD-1 PD-L1 interaction is being inhibited by this anti-PD-L1 monoclonal antibody, that is atezolizumab, which result in enhanced T cell cancer related immunity. So this is the schema of the study. It's the phase 3 trial where the chemotherapy naive PS01 patients of extensive stage small cell lung cancer were either randomized to carboplatin etoposide plus atezolizumab or placebo every 3 weekly for 4 cycles, followed by atezolizumab maintenance. These are the baseline characteristics. As far as baseline characteristics are concerned, they were very well matched in terms of age, sex, race, ECOG performance status, smoking status, tumor mutation burden, as well as brain metastasis. This is the overall survival shown by Kaplan-Meier curves. You can see the separation of over the Kaplan-Meier curves, albeit not immediate separation, but later, but sustained. At 12-month overall survival is around 51.7% in atezolizumab arm versus 38.2% in chemotherapy plus placebo arm. That is with the hazard ratio of 0.70. It means less than 30% risk of death with a significant p-value. That updated analysis of overall survival is quite much better. That is showing 18-month overall survival of 34% versus 21% with hazard ratio of 0.76, reduced death by 24%. The difference between atezolizumab and the CASPIAN trial, which was investigating durvalumab, is that CASPIAN trial could not show the stratification, PFS stratification of significance. That is not still done. But atezolizumab plus chemotherapy has resulted in significantly prolonged progression-free survival also. And with the hazard ratio 0.77, that is also statistically significant as per the p-value. The overall response rates was similar between both arms, the atezolizumab and the chemotherapy plus placebo arm. But the patient with ongoing response were much more in the atezolizumab arm as compared to the chemotherapy plus placebo arm. As far as subgroup analysis has been confirmed, you can see the forest plot that almost all subgroups were benefited with this atezolizumab based combination. In brain metastasis, we can see the hazard ratio not favoring this combination, but though the numbers are very less, so a concrete evidence or a statement could not be made that brain metastasis patients are not being deriving benefit with this particular combination. As far as PD-L1 expression is concerned, you can see that all the patients, irrespective of PD-L1 expression, were benefited by this combination of atezolizumab plus chemotherapy arm. This is PFS subgroups. As with the overall survival subgroups in the forest plot, the PFS subgroup is in concurrence with the OS subgroups, except for brain metastasis. All other subgroups, majority of the subgroups, achieved benefit with this chemoimmunotherapy arm. The safety profile of IMPOWER 133 was in concurrence with the known risk of the individual therapy components. As you can see that the treatment-related grade 3-4 adverse events are almost similar in both the arms. Treatment-related serious adverse events are almost similar in both the arms, though there's a slightly more number of patients withdrawing from atezolizumab arm than the placebo arm, that is 11.6% versus 2.6%. So depending upon or because of the concrete evidence of showing improvement in overall survival and progression-free survival in almost all the subgroup of patients, the treatment guideline, NCCN, as well as European Medicines Agency have recommended the combination of atezolizumab with induction chemotherapy, carboplatin plus etoposide. I would like to say that carboplatin and cisplatin can be substituted because at least 4 randomized trials have shown that both are effective in this particular setting. So this has been recommended for the first line treatment of patients with extensive stage small cell lung cancer. This is NCCN treatment guidelines for patients with extensive stage small cell lung cancer. Now include atezolizumab plus chemotherapy. As you can see the downwards, that is category 1. The patient with the stable disease or any type of response are being given maintenance atezolizumab after 4 cycles of chemotherapy plus immunotherapy. So to summarize, as I was telling in the first 2-3 slides, that there's not been any concrete development in the systemic therapy for extended stage small cell lung cancer, and this is the disease which is associated with very dismal and poor prognosis with 5-year overall survival less than 2%. So IMPOWER 133 is the first study in last 2 decades to show a clinically meaningful improvement in overall survival over the current standard therapy in first-line extended stage small cell lung cancer. The addition of immunotherapy, that is atezolizumab, to carboplatin has resulted in significant improvement in overall survival and progression-free survival. That is superior in terms of the Caspian trial, not the number-wise, though the cross-trial comparison should not be done. But at least the Caspian trial could not show the improvement in progression-free survival, or that is yet done. The addition of atezolizumab has shown the improvement in both overall survival as well as progression-free survival. Updated median overall survival is 12.3 versus 10.3, and median progression-free survival is 5.2 versus 4.3 months. As far as PD-L1 expression is concerned, all the patients, irrespective of PD-L1 status, achieved benefit with this chemoimmunotherapy combination. And also, this chemoimmunotherapy combination is well tolerated. The safety profile is in concurrence with the toxicity of the individual therapy component. Rate of hematological side effects was similar between the treatment groups. So, in conclusion, the data suggests that in this particularly rapidly aggressive malignancy with early disseminated spread and majority of the patient presenting with extended stage disease, atezolizumab plus carboplatin and etoposide is a new standard of care for the treatment of extended stage small cell lung cancer. Thank you.
Thank you. Yeah, thank you, Dr. Dubey, for a very crisp presentation. And with this, we come to the last session for today. And I would not like to keep you waiting too long for your dinner, because we have been running around 15 minutes behind the schedule. So the last session today is a case-based discussion, and I also request all our previous speakers and other people to join us for this panel discussion. And please post your questions if you have any while we are discussing these case-based discussion. So I'll start sharing my screen. For this expert panel, I like to invite Dr. Rajat Shah, who is senior consultant at Max Institute of Cancer Care at Max Vaishali and Max Paparganj. Dr. Vikas Goswami, again senior consultant at Max Vaishali and Max Paparganj and Max Noida. And Dr. Tejendra Singh, who is consultant oncologist at Central Railway Hospital. Dr. Aparna Dhar, who is a senior and head of molecular oncology at Core Diagnostics, and Dr. S. Narayan sir, who is at Military Hospital Dehradun. He's a senior specialist. And Dr. Shubham, I'm actually going to miss because he has some personal engagement and he had to leave for that. So he could not join us for panel. But then any of us could actually pitch in for him with respect to the surgical aspect wherever it is there. So do I have all the people on board? Dr. Rajat, Dr. Vikas, Dr. Tejendra sir, Dr. Aparna, and Dr. Narayanan.
Yes, yes.
Okay. Thank you all of you for joining me here. And just before I go to the case discussion, we are planning a national conference with the Indian Society for Study of Lung Cancer. It's a 4-day conference. Next month, 26th, 27th, and 3rd and 4th of October. So we'll cover all aspects of lung cancer. And this will again be a platform where both all oncologists as well as pulmonologists will form a team and decide and brainstorm as to what is the latest and what best can be done for lung cancer. So I invite you, all of you, in my personal capacity as part of the organizing committee, to join us for this lovely conference, which will be next month. So coming to the case, so this case is a 54-year-old male, a former smoker with a 20 patient years, lung cancer adenocarcinoma diagnosed on biopsy, and was found to have EGFR exon 19 deletion positive. So the past medical history is type 2 diabetes and ECOG performance status is 0. Patient was suffering from pleuritic chest pain and there was shortness of breath over the past 1 month. The scans confirmed that there was a lung cancer, and there was also a CT scan showed there was an adrenal gland metastasis. The brain metastasis was found to be negative on MRI. So my first question, actually, Shubham is not there. I planned this question for him, but then I'll ask Dr. Vikas. Dr. Vikas, which site would you choose for tissue biopsy? Is there a site which is preferred, or any site would be do, which will do if it is accessible? Dr. Vikas, yeah, please unmute yourself. Dr. Rajat, if you could pitch in. Dr. Rajat.
Yeah, I think so. We should preferably choose the primary site for the biopsy. That is, if the primary site is not accessible, then we can choose any lymph nodal or liver or bone or site for biopsy. But if given a choice, I would choose the primary site or the lung mass for a biopsy, either through bronchoscopic route or through a CT guided biopsy route.
Okay. Dr. Aparna, I'd like to ask you, will it make a difference to you as a molecular oncologist if the tissue is from the primary site or is it from metastatic site? What do you feel as molecular oncologist? Which tissue would you prefer, or for you it's same?
So when it's an initial diagnosis, I'm pretty comfortable with it being the metastatic or the primary site. However, when a disease progresses and there are new metastatic sites, then I prefer the new metastatic site for the biopsy, because that will most likely give me the molecular profiling in real time versus what possibly could be there in the primary. It would have some of the more, even the small driver mutations or even small passenger mutations that could be playing a very key role in having this disease become, for progression. So right now, if this is, when you're just diagnosis, I'm comfortable with either. On progression, I prefer the metastatic if it's accessible.
Dr. Tajinder, what would be your choice?
For biopsy?
Yeah, biopsy. So
Yeah.
just like the primary or the metastatic or anything will be fine.
Yeah, primarily we should do from the lung initially.
Okay.
But regarding the metastasis, I feel we should do the FNAC to confirm whether it is a metastatic or not. Although I think PET CT suggestive of adrenal mets, it is common, but if we are able to document that it is a metastatic, then it will be more confirmatory that it is a stage 4 disease and we are dealing with a stage 4, as it is a single oligometastatic.
Okay. Dr. Aparna,
Dr. Sajjan, am I audible?
Dr.
Vikas here. Yeah. Am I audible now?
Yeah, you are audible. Yeah.
Okay, thank you.
So Dr. Aparna, one question for you. Is there a case for liquid biopsy upfront?
Ideally, I would prefer doing a tissue biopsy. If a tissue biopsy is not accessible, or the patient is, of old age or has other comorbidities, and we can't go in for a tissue biopsy, that's the only time I will go in for a liquid biopsy. But in liquid biopsy, the caveat is it has to be a minimum stage 3B, because then only you're able to isolate the burden of having the circulating tumor DNA is high. So that gives me a better sensitivity and specificity for isolating the ctDNA and giving you a molecular profile, an accurate profile.
So it will be of use only in a selected population, and if
absolutely
the patient is not able to, or we are not able to get a diagnosis, and we accept that. But otherwise, we will always like to go for a tissue.
It's always the first choice.
So this patient was found to be EGFR mutation positive. But if that was taking time for a person, then should we actually wait for mutation test results, or should we initiate the first line of systemic therapy? The question is for Dr. Vikas. Dr. Vikas, what would you do in your practice? Would you like to wait, or would you like to start the systemic treatment and then change accordingly?
Dr. Sajjan, in this particular case, probably I'll start with the systemic therapy. However, in a case where the disease load is not much, probably I will wait, because now the turnaround time is not that much. However, this case which you showed had adrenal mets and I think liver mets also, if I'm not wrong.
No,
Probably,
yeah, only had adrenal mets, and there was some symptomatology like chest pain and then some
yeah.
breathlessness.
So symptomatology was there. So probably I would have started with chemotherapy.
Okay. Dr. Rajat, what will be your take for this patient? Would you like to wait for the report of EGFR or would like to start?
So if the patient is not very symptomatic, I would like to wait. But if the patient is symptomatic, we should start with the pemetrexed platinum-based chemotherapy rather than wait for the report.
So based upon the symptoms and disease burden, you will take the decision.
Yes, yes.
Okay. So if the patient was 76 years of age and instead of 54, and patient was had multiple comorbidities, then still would we be working with that patient so much? Will we offer that patient best supportive care, or will try to search for actionable mutation, or we will take a shared decision based upon the patient preference? I'd like to have each of your views. First, starting with Dr. Tejinder, what would be your choice, boss?
At 76 years of age, probably with comorbidities, it will be difficult to tolerate the chemotherapy at this stage. So I will try to wait for the actionable mutations. And now some drugs are available at low cost also, like first generation Jeftinib or others. So we can wait for the mutations.
Okay.
And we will start, particularly I will wait for the mutations and then start the targeted therapy if possible, if they are actionable mutations positive.
Okay, okay. Dr. Narayanan, what will be your choice in the elderly population, especially the patient has got multiple comorbidities? Would you be really keen to treat such patients, or would you like to send them back to home and on best supportive care? Dr. Narayanan, can you hear us, or please unmute yourself if you are on mute? I think there is some issue with. Okay, I think we'll go to the next session. I think this will be very important. So, friends, this is what I would like to ask from you again. So, coming back to the original case. So, if the patient is found to be EGFR del19 positive, then what will be your choice in 2020? So, Dr. Vikas, I'll take your choice first. What will, given a choice, you have all these options. If the patient is affordable, you answer, and if the patient is not affordable, then you answer. Affordable and
So
non-affordable.
if the patient is affordable, the answer is quite clear. I'll start with osimertinib. And in case affordability is an issue, then I'll go with choice number one, Jeftinib and erlotinib.
Okay. Dr. Rajat, will your choice for a non-affordable patient be different from Dr. Vikas' choice?
For a relatively non-affordable patient, I think so. Option number 4, keeping in mind the Tata regimen, the TKI plus chemotherapy regimen, may be offered. This is not very expensive and should be offered to our patients, provided he has a good fitness for chemotherapy. A TKI plus chemotherapy option, I would like to go over.
Okay.
If the patient is affordable, yes, osimertinib is the absolutely non-headache kind of a treatment option, whereby it is so very effective. So means I'm having a very good performance status. Means this PFS advantage. We can very easily give it for at least 2 years to 2.5 years before actually thinking anything else.
I think. Do we have Dr. Sushant here? If he can pitch in, Dr. Sushant, are you here or I can't see you? Meanwhile, if I take his call, I like to ask Dr. Tejinder, boss, what would be your patients actually are able to get reimbursement or they're able to afford the government? So, what would be your choice if a patient is able to get support from the government?
Yeah, actually, we decide as per the number one, the patient is having brain mets are positive or not. As this patient is brain mets is negative.
Okay.
So if it would have been brain mets positive, then osimertinib we usually give in the first line.
Okay. Okay. Okay.
If it is brain metastasis is negative, then we see the age of the patient. If, for example, the age of the patient is 76 or 78, the overall survival is less as compared to a younger patient. So if the patient is young, then we will give osimertinib as the first line.
Okay.
With the otherwise, we will give chemo plus target therapy, means geftinib, or initially in the first line.
Yeah. So from what I gather from your this is that given a choice, best drug will be osimertinib. But then if there are financial constraints or there are other issues, then we might have to go for either choice of combination of chemotherapy with first generation TKI or giving first generation TKI. And I think this is what has been highlighted even in the new changes in the NCCN guidelines, where osimertinib has been put up as a preferred category, and but all others also are taken as a category 1 recommendation. And certain situations where they have tried to use chemotherapy along, though this has not been put up in the NCCN guidelines, but then the Tata's data shows that there might be a role of using first generation EGFR inhibitor along with chemotherapy, and which might be a good way forward. So this I think already has been covered extensively by Dr. Sushant. So this also he showed. Just to ask you, what is your experience with osimertinib? How happy are you with use of osimertinib? Dr. Tejinder, how do you feel about the side effect profile of osimertinib?
I think this is the one of the best drug according to the side effects. If we see, even I have not seen even a single. We are having currently 4 patients on osimertinib, and not a single patient has drug interruption due to the side effects. So it is a patient-friendly drug. As compared to geftinib, even erlotinib, afatinib, they have shown significant side effects, and we have to interrupt the doses. But particularly with the osimertinib, all the 4 patients who are taking this drug for almost 8 months, or some patients is showing for last 1 year, I have not stopped even for a single day due to the toxicity. So this is a very patient-friendly drug.
Very patient-friendly. Dr. Rajat, have you seen any specific side effects with respect to use of osimertinib in your patients?
No, I don't think so. No, as Dr. Tejinder also pointed out, it's a very patient-friendly drug, and we haven't observed any significant side effects. No major skin reactions, no major paronychia or anything. All these are very distressing symptoms with erlotinib or gefitinib, but not seen. Dacometinib and afatinib is even a bit more toxic as compared to erlotinib or gefitinib, but osimertinib is pretty okay to handle.
Okay. So now, if a patient who has been taking first line or second line TKI progresses on therapy, or in fact, for that matter, even if on osimertinib, what would you prefer when the patient progresses? A liquid biopsy alone, a tissue biopsy, or a liquid plus followed by a tissue biopsy, FNAC, not do anything, no biopsies, change the treatment. So for two scenarios. One is the patient is on osimertinib. So Dr. Rajat, I will start with you again. What is your choice if a patient is on osimertinib? A patient progresses, what would you do?
If the patient is on osimertinib or not on osimertinib?
First on osimertinib, patient progresses, what would you do? You do something or you not do anything, and you will change to chemotherapy, number 1.
Actually, we don't have any actionable mutations analysis. So what we do, I would still prefer to do a biopsy, because I may document a MET mutation or a MET amplification, or I may document a small cell transformation. So these are 2 things. Theoretically speaking, we have molecules against MET amplification, and for small cell transformation, obviously we can shift to chemotherapy. So these 2 things we can definitely check on a repeat biopsy after osimertinib progression.
Dr. Vikas, your inputs if the patient is on osimertinib versus the patient is on both the scenarios. I'd like to have your inputs.
So for patients who are not on osimertinib, if it's a brain metastasis where the disease has progressed, probably osimertinib is the best drug to be put on. If it is outside the brain, then probably I like to search for T790M mutation. And if that's the case, then my choice becomes osimertinib. If it's not the case, then probably I'll shift over to systemic therapy. For the patients on osimertinib, by and large, what Dr. Rajat has said, I agree with that.
Okay. I think that's very wonderful, because we have to understand, because sometimes a patient might actually have small cell transformation or CMET amplification, which might otherwise be missed on liquid biopsy. But I like to also have input from Dr. Aparna as to what would you do. What would you prefer? Would you prefer only liquid biopsy followed by reflex testing, or you are happier having a tissue diagnosis instead of liquid biopsy in a patient who progresses on osimertinib?
So in the case of when a patient progresses on osimertinib, I would like to go in for a liquid biopsy here. And the reason is, as I think Dr. Rajat very rightfully said, that if I even want to call out a small cell transformation, which is looking for the RB1 gene, or I'm going to look for a MET amplification. So at that point, the sensitivity of calling out these mutations, they could be as small, have a variant allele frequency of as small as 0.1 or 0.2%, and could be causing as much damage as your other mutations, which are having a VAF of 30 to 33%. And I think the sensitivity of catching something so small, and because of tumor heterogeneity and the disease is progressing, I would like to go in for a liquid biopsy at this point when a patient has progressed on osimertinib. If it was not osimertinib, I would be a little, again, you're going to be looking for the T790M at that point. So again, a liquid biopsy would be recommended at that point. If that's negative, then maybe I would go in for a tissue. But I think at this point, liquid biopsy would be my go-to.
So you will prefer.
Sajjan, I have a question, honestly,
Go
to
ahead.
all the doctors. A patient who's progressed on erlotinib and who is not harboring a T790M mutation, should we be giving osimertinib or not?
Okay. So, Dr. I think Dr. Sushant, is Dr. Sushant around? Dr. Sushant? So, okay. So the question is whether after first generation, if there's no T790M mutation, can we still use a third generation TKI? There's no correct answer to that. But again, we can check for the mutation which has happened. Probably if a mutation is sensitive enough again to your osimertinib, you can try that. Otherwise, what we can do is we can go for a chemotherapy window, and probably after that we might use another EGFR inhibitor. But I think none of us knows the answer for this question. Dr. Rajat, do you have any inputs on this? Dr. Rajat, any inputs on Dr. Vikas' question?
Obviously, if you are doing a liquid biopsy, you don't find a T790.
No, on tissue biopsy.
Yeah, okay.
tissue
You have done that tissue biopsy also, still no T790. Again, then I think so we should aggressively check for other mutations. NTRK is there,
And
MOT is there.
let's if the only site of progression is brain and it's not amenable to T790M mutation check, then what are we wrong if we just give osimertinib without that?
That's an interesting situation. I would be prompted to give osimertinib. If it is a brain, we know it's an excellent penetrability.
Because I read somewhere in brain, irrespective of T790, we should give.
Yes.
But I wanted your other people's opinion on that.
So, Dr. Vikas, I also like to pitch in. So, there's data which shows that even on erlotinib, and you only have brain metastasis, you can actually control those brain metastases and continue on erlotinib also. So, if we can continue erlotinib, we can also switch over to osimertinib. I think that's a logical kind of explanation for this.
Okay, fine. That's a good point.
Yeah. So, the next question is, what are the treatment options for patients progressing on osimertinib? So, Dr. Tejinder, if a patient, like your patients are doing really well with osimertinib, whenever they will actually progress, so what would be your choice? Go to re-challenge with first or second generation TKIs, give chemotherapy, TKI plus chemotherapy, go for immunotherapy, other targeted therapies. So what would you be preferring in a patient who progresses on osimertinib?
If we have started in a first line osimertinib,
yeah,
I think I will prefer chemotherapy after progression with the osimertinib.
Okay. Dr. Vikas, what would be your choice? Patient progressing on osimertinib? Biopsies.
So I agree with Dr. Tejinder. Chemotherapy, yes. I'm not sure whether combining immunotherapy and chemotherapy is it the right choice or not. Probably I'll like to look at the data of PDL1 for that, but chemotherapy certainly yes.
Dr. Rajat?
Yeah, if I think so, no other actionable mutation is there, we should then go to chemotherapy only. Yeah.
Yes,
platinum.
So yeah, if it is oligometastasis, probably you could control with local treatment, continue osimertinib. If there are extensive disease, go for chemotherapy. And that's what is mentioned in NCCN. So one more thing which is very important: if the patient is found to be PD-L1 positive, so would you be happy using PD-L1 at this point in time, or would you like to combine it with chemotherapy, or would you like to go for chemotherapy alone? Dr. Rajat, if a patient is found to be PD-L1 positive, in
what is the extent of positivity and what is the platform?
more than 50% positive.
So if more than 50% positive, let us give him a chance with a single agent immunotherapy.
Okay. Dr. Vikas, do you have any other opinion?
Actually, I kind of feel that even if more than 50%, we should initially give a combination and maybe later on go on to immuno alone. Reason being, there are so many cases where we have seen that despite a very high PD-L1 positivity, the response is not there.
Okay.
So in a case where we want a response, symptomatic case, probably I'll go with the combination and then shift over to immunotherapy later on.
Okay. So I think you got a very valid point, especially with driven oncogenic driver dependent tumors. Even if they are PD-L1 positive, the data shows that they might not respond optimally to PD-L1 inhibitors, and now there is some data emerging with a combination of chemotherapy along with PD-L1. I think more data will let us know as to which is the best way forward for such patient. In fact, another patient here, the second case, I'll just briefly rush to the same patient, 65 female, again having adenocarcinoma TTF1 and APSIN1 positive, and PD-L1 expression was 55% and oncogenic, again exon 19 deletion. So such patients, I think if the patient does not have any CNS symptoms, would you like to go for a brain scan? Yes or no? I think Dr. Vikas, I'll ask you whether brain MRI is required for patients or not.
If it is asymptomatic, I won't go. Though the recommendations are there, but pragmatically I won't.
Dr. Rajat?
I generally do not go for a brain scan with an asymptomatic presentation.
Okay. Dr. Tejinder?
Yeah, I agree with both of them always. In generally, we do not go initially.
Sir, but sir, I have a point, sir. Like it's been like the conventional teaching is that in stage 3 and 4, there are more than 20% of patients who will have upfront brain metastasis. So there'll be asymptomatic also. And so I guess we should do in at least a metastatic case, we should do a brain scan upfront.
Dr. Dubey, the
yes,
question is, are you doing it? We
yes,
all
sir,
are aware of the.
We are doing, sir.
Yeah.
We are doing, sir.
Yeah. So well, I'll just interrupt. So in fact, we also thought the same way, because I think there was a previous conventional teaching that MRI is not required for asymptomatic brain mets, but I think new guidelines have incorporated this as a part of initial screening. So now we have got MRI brain as well as PET scan as a part of the initial screening. Possibly, I think it adds some value to the initial control and choice of therapy. That's why it has been incorporated, because it was not there in previous NCCN guidelines, but now it has been incorporated. So this one thing which has happened here.
So one thing I like to point out, Sajjan, may I speak?
Yeah, sir. Yeah.
Yeah. So I am Sushant. So what I'm saying that it has been included because if after 3 months the patient becomes symptomatic, so we don't know whether the brain mets were initially present or not present, the patient has progressed or not progressed. So one of the school of thought is to do at the baseline is for the staging workup.
I think, yeah, I agree with that. Another point which we might actually, we have to actually discuss. We don't have our radiation oncologist on board here. Otherwise, I would have actually discussed. I know whether we have somebody in the attendance who could help us. What about asymptomatic brain mets? Are we doing SRS? Are we actually doing? Because what I feel is that probably if a patient, even if the patient is asymptomatic, there is a case for radiosurgery. So, Dr. Rajat, what do you feel? Are we going for symptomatic or going for only asymptomatic? What is the current this thing? If you find brain metastasis, solitary brain metastasis, small size. So what is and the patient is EGFR positive. So what would you do?
If the patient is EGFR positive, not exposed to any other treatment, I would definitely go for osimertinib first. I would not go for radiation to the brain. But if the patient is not able to afford osimertinib by any chance, then I would definitely like to ablate the brain by giving stereotactic radiosurgery or yeah.
Okay, Dr. Vikas, what would be your this thing?
So, Sajan, again, like previous question, theoretically, what Dr. Rajat is saying, I totally agree with it. But practically, I would be greedy. I would rather give SBRT and then give osimertinib.
So basically, I have actually seen the brain mets totally melt away with osimertinib. So you have to see it to believe it. Means we were in one of our patients, we were debating between giving radiation or not giving. The patient himself chose that I will not take radiation.
Okay.
He took the risk upon himself. And with the osimertinib, the brain mets actually melted within 1 to 1.5 months.
Okay. So I think a kind of approach might be valuable where when we know that we are treating osimertinib, we could have a close watch on the patient's brain MRI and check whether it's a stable brain metastasis responding to osimertinib. If the response is not there, then we go for a local treatment for that patient. Okay, I think with this, because in the interest of time, I like to stop it here. And thank you all of you for being a part of this panel, and thank you again. And yeah. So if you have any other questions, then I will be happy to put to our expert panel here.
Dr. Sajjan, just one question.
Yeah.
If which I started when there is a oligometastatic disease on PET CT. Just in this case, there was one adrenal mets. Would you like to go for FNAC to confirm whether it is a metastasis, or as general by just PET CT we start as a stage 4 disease? Whether anybody?
Okay, yeah, Dr. Rajat, can you take up this question?
Adrenals are a little bit difficult to FNAC. So if it is possible, yes, we can go ahead with an FNAC. But sometimes our interventional people say that it is a bit difficult site to biopsy or FNAC. I would believe the PET scan.
Okay. All right. Thank you.
Okay. Any other questions you could put in the chat box? I will be happy. There's one more question, which is like, the primary site is positive for malignancy. Should we prove the metastatic site, as well as should we assume that metastatic site to be PET positive? I think that's already answered now. So we don't have to keep proving all other metastatic sites if the PET scan shows that there's a reasonable FDG avid lesion there. If there's doubt, then definitely, or if it's an oligometastatic disease, in certain scenarios we might have to prove it. But mostly we will take that as a part of disease. Especially with stage 3, we are going for mediastinoscopy, or like we had EBUS, where we have to actually very critical for us to prove the lymph nodes are positive or not. That's where we actually go and prove. Otherwise, if it is metastatic disease and we have 3 or 4 sites, then we might not go for any biopsies. So I think with this, I'll conclude this panel discussion, and thank you all for joining for this panel discussion. And,
Thanks.
Yeah, do we have any question? Okay, thank you so much. And to conclude this meeting, I would have loved that Shubham would have been here, because there's some medical emergency he had to leave. But then on behalf of the organizers and on behalf of Spring Hope Cancer Foundation, Asian Journal of Oncology, and our sponsors for today, AstraZeneca, Roche, Intas, as well as Axiomax, I would like to thank all of you and thank my organizers for putting up such a lovely event for us. And it was a wonderful interaction and a lot of learning for all of us here. And thank you so much, and have a lovely night and enjoy your dinner. And we'll meet on some other platform some other day. Thank you so much. Thank you so much.
Thank you.
Thank you.